Geno Makin, hope for tomorrow. Pre-exposure prophylaxis in Africa. What is the future? If you don't know where you're coming from, you cannot tell where you're going. Maya Angelou. I'd like to thank the organizers for the opportunity to share with you our thoughts about pre-exposure prophylaxis and the future. I will use my country, Kenya, as a prototype for what we can think about for pre-exposure prophylaxis in sub-Saharan Africa. We have to know where we've come from in order to know where we are going to. What's the landscape like in Kenya? In this schema, I'd like you to look at what the overall incidence was like in Kenya and what our targets were for reducing the incidence. In general, we have been able to achieve our targets of reduction in new infections among male, among adults in general, and in the overall population. Where we haven't done as well is among the females. And of course, as a result, this also reflects upon children. I'd like you to think about the geographic focus and the priority populations who we target pre-exposure prophylaxis for. Adolescent girls and young women, female sex workers, men who have sex with men, serodiscordant couples, and of course, we cannot forget the general population. In Kenya, we have targets for each of these populations, hoping to be able to ensure access to individuals who need pre-exposure prophylaxis. But let me take us back to the history of where we've come from so that we can think about where we are going to. After the early trials for Kenya, we formed a national technical working group in 2016. The demonstration projects that started within that year were able to provide information that eventually saw approval of the generic formulations for pre-exposure prophylaxis. By May 2017, we had launched a national framework and started rolling out pre-exposure prophylaxis. What are some of the lessons that have been learned? PrEP was highly accessible, but this was only after intensive awareness and demand creation. The uptake was high initially, as individuals were keen to try it out. We ran into roadblocks. Persistence was a challenge. Adherence was a challenge for some. Some individuals felt PrEP just wasn't for them. For some of them, taking a pill daily when they were not unwell was challenging. The highly mobile younger population that is at risk tends to relocate in search of education or work opportunities. And then there wasn't the social support that made it easy for individuals who wanted to take PrEP to continue on it. But let's think about the regional uptake of PrEP, not just for Kenya, but for the whole world. And in this slide from AVAC, you can see that though sub-Saharan Africa was onto a very slow start, by the last quarter of 2020, most of the uptake of pre-exposure prophylaxis was from the sub-Saharan African region. If I focus it back to Kenya, who's currently taking PrEP? This pie chart shows you who has the lion's share. in terms of the numbers of individuals who are on PrEP. The general population, about 31%. Discordant couples, taking the lion's share, 39%. Female sex workers at 21%. And lower numbers among men who have sex with men and people who inject drugs. What does that mean for us as we think about the future and these key populations who do need to access PrEP? Demand creation is one of the important lessons we need to think about. I still get surprised at the number of individuals who have no idea that a pill a day could keep HIV away. We haven't provided enough information or saturated information to enable anyone who might be at risk to access it. But even as we create demand, we must ensure that there is access and there is service delivery within healthcare facilities that may be already overburdened with other infectious conditions and other challenges. Once the individual who initiates PrEP takes it, how do we support them to adhere? How do we ensure that they can receive the support to be persistent in their taking of their pre-exposure prophylaxis? Policy adaptation and implementation of programs that allow for PrEP to be expanded and available are really important. And in the current landscape, where a lot of the PrEP has been funded through either PEPFAR or Global Fund, and with the diminishing funds coming from those particular areas, there is need to think about how do we sustain the costs of the programs that are offering PrEP. I'd like us to think for a moment about demand creation. The population in this region is expected to be about 1.7 billion by 2030. While currently the internet access may be at just under a quarter, it is expected that 3/4 of this population will have access by 2030. So as we create demand, can we think about more social media, virtual, internet-based platforms that provide information and enable individuals to be aware of what their options are? But as we make this information available, the question is, how do we provide the PrEP? We must think about moving from a predominantly healthcare facility, hospital-based access points, because this is a promotive product for avoiding infection, not for individuals who are unwell who need to come and get treatment. How can we enable access to testing? How can we make it more friendly? Must it require a provider? What are the self-testing strategies that would work? Can we use our antenatal care settings, our mother and baby clinic settings, any places where individuals who are well can be accessed to enable them to have opportunities to test and to access PrEP? Of course, there are target populations who we know are really at risk. The sexually transmitted clinics would be a point at which individuals should clearly access PrEP. However, many of these have been dismantled over the many years and may no longer have active service provision. Can we go beyond healthcare facilities to think about community-based options? Retail pharmacies, dispensaries. What are the safe spaces in which young individuals needing to access PrEP can actually access it? Are peer models viable? Remembering that these products are, however, prescription drugs that do require, at some level, oversight or interaction with an individual who has the required training as a healthcare worker. I think there are lessons we can learn from the contraceptive world. Contraception, like PrEP, is for prevention. for an individual who is well, but who needs to manage a certain aspect of their reproductive health life. How can we learn lessons from the contraceptive world to think about service delivery? How can we engage with healthcare providers who are a major stakeholder in being able to roll out PrEP? We recognize from this world that the high cost of initial service setup is often offset downstream as services become tailor-made and as access is improved and as the numbers accessing the services increase. How regularly should individuals who are on pre-exposure prophylaxis come in? We know that PrEP is not for life. It is for those periods when one does know that they're at risk and need to be protected. As some of the bilateral donor-funded programs reduce their funding, how can we ensure that there's subsidized government funding and support to enable citizenry access these products? And how do we deal with the gender inequities, recognizing that often partners play a key role in either enabling or not enabling access and use of these products? Remember that it's not an overnight thing. It took 10 years for PrEP to be available in many countries in sub-Saharan Africa. And there was a need for political will and financial support to adopt and implement these strategies. This required advocacy. This required commitment. We also need, and it's still a work in progress, to ensure there's social support and community involvement. Stigma is still a reality that people are dealing with even now. Because we will be implementing this in this season of COVID-19, I think there's some important lessons that we can learn from the pandemic. We need to prepare for an unexpected increase in demand of healthcare services. PrEP should be made available, even as we anticipate that our healthcare services will have an increased demand because of the pandemic. But maybe there are things we can benefit from. In this COVID pandemic, telemedicine has become part of our new normal. Can we borrow from it? What are the things that we can learn and implement by making PrEP available using telemedicine? Demedicalizing the access of services with some kind of remote clinical oversight. There have been challenges with supplies during the COVID pandemic, and how can we ensure that the chain supply of demand is made accessible despite the challenges with transportation and with goods moving from one place to another and with manufacturing? How do we use this same situation to ensure we can maintain robust documentation that allows for appropriate decision-making while reducing the burden of unnecessary documentation? And one important factor that we have learned as we've thought about the COVID-19 vaccine access and distribution, unless we address issues of racial and ethnic disparities, we will not be able to keep people healthy and to provide the services that they need if we do not address these concerns within the global world that we live in. I would like to acknowledge my team for their support in the preparation and in thinking about what the future of PrEP looks like for us. And as I end, and thank you for listening to me, I would like to ask you a question. What's your role and what part can you play in making PrEP for Africa a reality? Thank you.